first of all, hello to everybody, and you're very welcome to today's session, the session of the International Deprescribing Journal Club that's hosted by the European Society of Clinical Pharmacy. The Journal Club is the product of a collaboration between the German Deprescribing Network, the Australian Deprescribing Network, the US Deprescribing Network, Network of Europe Researchers in Deprescribing, the European Society of Clinical Pharmacy, and the Canadian Medication Appropriateness and Deprescribing Networks. So to start, we do want to thank all of these groups for their efforts in collaborating with us to plan this session. So I'm Christine Ryan. I'm Professor in Practice of Pharmacy in Trinity College Dublin. I lead a research group that looks at ensuring patients in vulnerable populations have the best, most effective medicines available to them. So really around medication safety for vulnerable populations. I'm also the director of our MPharm program for the pharmacy program in the school. I'll be moderating the session, but before we start, we do have a little bit of housekeeping. To help us ensure good audio quality during the speaker's presentation, please keep your microphone muted. Because not everyone is able to attend live, especially since we are living in different time zones, we will be recording these sessions, so the session is actually already on record. Please take note that this recording will be posted on the Canadian Medication Appropriateness and Deprescribing Network YouTube channel later today. The recording, as well as the PDF version of the slides, will be posted on deprescribingnetwork.ca/journal club, journal-club. You can also consult this webpage to view all previous Journal Club sessions. It gives me great pleasure to introduce our speaker, Dr. Juliette O'Connell. Juliette is a pharmacist and she is an assistant professor here in the School of Pharmacy at Trinity College Dublin. Juliette leads the Medicines Optimisation Group for an Irish longitudinal study called the IDS-TILDA. So it's the intellectual disability supplement of the big TILDA study here in Trinity. And Juliette leads up the medication or medicines optimization program within that. So I think without further ado, I would be delighted to hand over to you, Juliette. If I'll stop sharing slides and then you can share yours.
Thank you.
Right button, stop sharing.
Okay, can you see the slides okay now?
Yes.
Perfect. Okay, so very welcome to this webinar. So the topic and the title today is Optimizing Medication for Vulnerable Populations, Translating Research into Practice. So as mentioned, I'm Dr. Juliette O'Connell and I'm with the School of Pharmacy and Pharmaceutical Sciences in Trinity College Dublin. And this is just an outline of what is going to be discussed during the webinar today. So first and foremost, I'm going to begin by describing some of the key patterns of medication use in vulnerable populations, and I have a specific focus within my own research on older adults with intellectual disability. And we will discuss some findings from the Intellectual Disability Supplement to the Irish Longitudinal Study on Aging, which we abbreviate to IDS-TILDA, in particular with regards to prescribing trends in this group, polypharmacy and anticholinergic burden. We'll recognise some of the challenges associated with medication use in this population, including adverse effects, and we will then go on and explain the development and validation process of a newly developed medicines optimization tool called the OPTIMA-ID tool, which has been developed specifically for older people with intellectual disability. We'll also have a look at how research findings can be translated into practical tools in order to support evidence-informed, person-centered prescribing. And towards the end, then, we'll briefly discuss how similar methodologies and approaches might be adapted for other vulnerable groups to improve medication safety and optimization. So first and foremost, I'd just like to offer a definition for intellectual disability, just to give an overview of the population that we are discussing when we mention people with intellectual disability. So intellectual disability is defined as a neurodevelopmental disorder which manifests early in life and is characterized by impairments of general mental abilities that affect adaptive functioning. And so 3 domains of function are primarily affected for individuals with intellectual disability. So these are conceptual skills. So there may be difficulties with language, reading, writing, mathematics, knowledge, and memory. With social skills that can include communication, making social judgments, and forming and maintaining relationships. And practical skills. So this includes skills in self-management in aspects of life like personal care, money management, etc. So historically, the most frequently used criteria for diagnosis of intellectual disability was intelligence quotient below approximately 70, along with impaired social skills and onset before age 18. However, the reliance on IQ tests alone for diagnosis of intellectual disability has now been superseded by the use of metrics to look at the level of adaptive behaviour deficits. So people with intellectual disability experience very different patterns of medical conditions to what we would see in the general population. And so 2 categories of morbidity experienced have been suggested, and these are associated or primary health conditions and then secondary health conditions. So associated health conditions are those which are directly related to the intellectual disability itself. And these tend to be conditions that might be genetically related. So for one key example would be hypothyroidism in people with Down syndrome, and also Alzheimer's dementia in people with Down syndrome. We also see very high levels of epilepsy, mobility problems, which can be linked to cerebral palsy, visual and hearing impairments, and mental health conditions tend to be quite prevalent in this group. The secondary health conditions are those that are said to occur at higher rates in people with intellectual disability than we would see in the general population, but they are still considered to be preventable. So a few examples of those would be obesity, gastroesophageal reflux, constipation and bowel obstruction, which are quite significant issues in this population, dental caries, and pneumonia. So very different patterns of morbidity. We also have quite a few health disparities in this group. Analysis has shown us that life expectancy for people with intellectual disability has been found to be 19 years lower than what we would see in the general population. Now, this is still an improvement because back in the 1920s, the average life expectancy for a person with Down syndrome was around 9 years of age, whereas now it tends to be more around 50, 60 years of age, but it's still a lower life expectancy than what we would see in the general population. So we have essentially a new phenomenon in that we have individuals with intellectual disability are living into old age, but with that comes potential for health disparities that need to be addressed. One of these includes multimorbidity. So 7 out of 10 adults with intellectual disability over the age of 40 experience multimorbidity. And the most prevalent co-occurrence of morbidity is mental illness with neurological disease. Now, when we talk about aging with intellectual disability, we choose the threshold of over 40 years of age because people with intellectual disability tend to experience the effects of aging at a much earlier point in their lifetime. So in particular, people with Down syndrome will have evidence of Alzheimer's dementia from their 30s and onwards, whereas we wouldn't see that until later in the general population. I'll tell you a little bit about the IDS-TILDA study in a little while, but that has also been developed to run alongside a general population study of aging TILDA within Ireland, and so they have an age range of over 50. So there has been some research done around adverse medication effects in people with intellectual disability, and it has been found that they're more likely to experience drug-related adverse effects. And in particular, one study found that they're more likely to suffer from the movement-related adverse effects that come from using antipsychotics. This is something we'll discuss more because we tend to have very high rates of prescribing of antipsychotics in this group as well. So obviously we know as people age, they experience differences in pharmacokinetics and pharmacodynamics. So this is very well known and understood in the general population. However, it's also hypothesized that people with intellectual disability have differences in their responses to medications from earlier on in life. Now, here I say hypothesized because the evidence is still really being developed in this area, so we don't have an awful lot of evidence to tell us exactly what the differences are. But a few of the hypothesized causes include differences in brain structure and function, so that could impact on response to medications. People with intellectual disability are often exposed to polypharmacy, so multiple medicines use, and that in itself will give rise to the potential for drug-drug interactions. We also tend to see high levels of overweight and obesity in this group, so that's going to affect levels of body fat, which in turn can affect pharmacokinetics. And also there may be differences in genetics and the expression of metabolic enzymes, though specificity just to the intellectual disability population is still being established. So I'm very fortunate to be involved with the IDS-TILDA study, which I've mentioned it's a longitudinal study on aging, specifically looking at people with intellectual disability. So this is a study that is a member of a global family of longitudinal studies, and it has been designed to run in parallel to the general population study TILDA. And this is because the TILDA study, it wasn't possible for them to include people with intellectual disability because there are different mechanisms for consent and sampling and so on. So that's why the IDS-TILDA study was developed in order to make sure that people with intellectual disability were also being represented in aging research. And IDS-TILDA is led by principal investigator Professor Mary McCarran, who herself is a nurse in intellectual disability and has done extensive work on looking at aging and intellectual disability over her career. So the IDS-TILDA story started back in 2007. So this was around the time that the TILDA study was beginning. And so the first wave of data collection was in 2009, 2010, and we have subsequently had 5 waves of data collection. So about every 3 years, data collection takes place, and we refer to that as the wave. And field researchers have just started work on collecting data in wave 6 now just recently. And it's quite unique in the sense that it's the first nationally representative longitudinal study on aging with an intellectual disability, which is comparable to the general population. So the measures and the questions that are used in the IDS-TILDA study have been mapped to the questions and data being captured in the TILDA study so that we have that comparison between populations. The objectives of the IDS-TILDA study are to understand the health characteristics of people aging with an intellectual disability, to examine service needs and health service utilisation of people aging with an intellectual disability, to identify disparities in health status, especially as compared to TILDA findings on the general population, and to support evidence-informed policies, practices, and evaluation. So the IDS-TILDA study covers a very broad range of a person's life. It's underpinned by a comprehensive conceptual framework. So it looks at very important parts of life like social connection, usage of community services, involvement in the community, also looking at loneliness and connections and so on. And in addition, then physical health is examined. And obviously from a pharmacy and a prescribing point of view, we're particularly interested in looking at what medication burden looks like in this population. So we have conducted research in this area across the waves of the study. It has been found that over 50% of people in the population are exposed to polypharmacy, and that roughly breaks down to about 30% using 5 to 9 medications and 20% using 10 or more medications. So we have quite a degree of excessive polypharmacy as well. People with intellectual disability in the cohort have also reported high levels of anticholinergic exposure. So 71% anticholinergic exposure measured by the anticholinergic cognitive burden score. And we also examined drug burden index, which is a dose-related measure of exposure to anticholinergic and sedative medications, and found that nearly 80% of participants within the population are exposed to these medications. So we have very, very different patterns of prescribing, and I suppose that follows on from the different patterns of morbidity that we see in this population. So we tend to see higher levels of chronic conditions. So that's chronic conditions. So that means there is going to be more need for prescribing. But what's very interesting is that when we look at the most frequently reported classes of medications, we're seeing a very different picture to what we see in the TILDA population. So in the TILDA population, we see typically cardiovascular system agents, which are leading medications that are being used in that population. So you can see here lipid modifying agents, agents acting on the renin-angiotensin-aldosterone system, and antithrombotic agents. Whereas you can see quite the contrast on the left-hand side of the slide. You can see the graph there that is showing that the top 3 most frequently prescribed agents are antipsychotics, anti-epileptics, and laxatives in this group. And the other phenomenon that we see within this, when we look at polypharmacy at a closer level, is that we actually have quite a lot of intra-class polypharmacy. So we will have individuals who are using more than one agent from each of those groups. So as you can see, very, very different prescribing patterns, and obviously then scope for different exposure and adverse effects. So from cross-sectional analysis, we've seen that anticholinergic burden is associated with higher likelihood of reporting older age, a mental health condition, constipation, daytime dosing, and laxative use. And this is between multivariate and univariate level analyses. So older people with intellectual disability, they're often exposed to very high levels of anticholinergic medicine, and we can see that there are a number of adverse outcomes that are associated there. One of the sub-studies that works with IDS TILDA data is the examining quality, use, and impact of psychotropic use for older adults with intellectual disability, which we call the EQUIP study. Which is led by Dr. Maura O'Dwyer. And this study aimed to examine the quality and trends of psychotropic use of older adults with intellectual disability over a 10-year period. And that's important for us to have a good picture in order to inform practice and policy and give us potential to optimize medicine's use and health outcomes. So the study objectives were to examine the quality and changes in psychotropic medicine prescribing over the course of 10 years of the study. So that's wave 1 to wave 4 of the study, so 2010 to 2020. Investigate possible long-term side effects of psychotropic medicines and look at the impact of change in residence on change in psychotropic use. So I'm not going to go into a huge amount of detail on the findings from the EQUIP study, but I do want to mention really one of the key elements that has been published from this work is looking at the high rates of prescribing of psychotropic use over the study period. So it was actually found there was no change in the relatively high rate of psychotropic use over the 10 years. So you can see from the graph on the right-hand side of the slide, that stayed steady at around 62% approximately of individuals using any psychotropic. But there were some changes within the classes. So you can see antipsychotic use has stayed fairly steady, but we can see that there was actually an increase in prescribing of antidepressants across the timelines, and also a decrease in the prescribing of anxiolytic medications. And so this is going to be reflective of some of the policy changes within Ireland over the last number of years, particularly around prescribing anxiolytics in this group. One of the other key findings from this study was that psychotropic polypharmacy is significantly associated with dependence in activities of daily living over the 10-year period. So we can see that there is very high levels of psychotropic prescribing, high levels of polypharmacy in this group, and that it is associated with outcomes. So that led us to consider what we can do to actually address this in practice. So we developed the Optimizing Pharmacotherapy and Improving Medication for Aging with Intellectual Disability, or OPTIMA-ID tool. And OPTIMA-ID is a medicines optimization tool which is specifically developed to address the needs of older people with intellectual disabilities. This is, again, a bolt-on study to IDS-TILDA. The study itself sits within the Trinity Centre for Aging and Intellectual Disability. And so the OPTIMA-ID research and the focus of it links in with the vision of the Trinity Centre, which is enhanced health, well-being and quality of life for people with intellectual disability as they age. It links in with the mission, which is looking to conduct rigorous, engaged research, particularly on the physical determinants of health and well-being, and then transforming those findings to inform, translating those findings to inform models of policy and practice. And OPTIMA-ID links in with a strategic priority of the Trinity Centre for Aging and Intellectual Disability, which is around medicines optimization and non-pharmacological interventions to increase quality of life. So the first thing, obviously, that we did was we developed our research team for OPTIMA-ID, and this was a multidisciplinary team. So as you can see here, we had a number of pharmacists involved in the development of the OPTIMA-ID tool, all with experience in looking at medication use in vulnerable populations, including obviously those with intellectual disability. We had a research assistant who also had worked on polypharmacy in her previous research. We also had 2 intellectual disability nurses who were on the research team, so Dr. Ailish Burke and Professor Mary McCarran, who's obviously a PI for IDS-TILDA as well. Our external PI for IDS-TILDA, Professor Philip McCallion, is based in Temple University in Philadelphia, and he's Professor of Social Work with particular expertise in intellectual disability. We also had the involvement of an intellectual disability psychiatrist, Dr. Niamh Mulryan. We had a pharmacy student who did some work on the project as well. She's now qualified as a pharmacist, but she did some of the initial work around literature review for the OPTIMA-ID tool. We have also some external input from Professor Deb, who's Professor of Neuropsychiatry in London. And most recently, although not involved in the initial development of the tool, we have had Miss Isabel Ryan, who is a pharmacist and PhD student, join the OPTIMA-ID team in order to take the tool, which is now being developed, and start to look at implementing it into practice. So as a little bit of background, I've already mentioned the fact that there are high levels of polypharmacy within this population. And so with those high levels of polypharmacy, there's also potential for there to be inappropriate polypharmacy to be occurring. We also have mentioned how we have unique morbidity patterns and subsequently unique prescribing patterns in this population. And the other issue we have when we're trying to look at optimizing medicines in this group is that we really have a lack of high quality evidence that's directly related to older adults with intellectual disability, because they're frequently not included in our gold standard randomized controlled trials. So one of the ways that has been used for other populations in order to overcome these issues is the development of a medicines optimization tool. So many tools have been developed to optimize older adults' prescriptions, but no comprehensive tool had been specifically designed for use in older adults with intellectual disability before OPTIMA-ID. So maybe many on the call will be familiar with Beers criteria and stop-start, which are obviously aiming for older populations. One of the other key references that we found helpful was the OPTIMIZE criteria. So these are specifically designed for adults with severe mental illness in order to improve their medications. And then the TOP-ID tool, which is a medicines optimization tool, which was recently developed for use in people with intellectual disability, but not specific to older adults with intellectual disability. So our aim from OPTIMA-ID was to develop an evidence-based tool to guide medicines optimization in older adults with intellectual disability. And we had a number of objectives within this. So first, to complete a literature search to develop the initial draft prescribing criteria. Then to conduct focus groups with experts in medication use in order to further develop the criteria. Triangulate the findings from objectives 1 and 2, and then validate that tool using Delphi consensus methodology with a panel of experts. So this is what the trajectory of the project looked like. We started off at stage 1, which was our literature review. We moved to research team review, focus groups, and Delphi validation there. So first and foremost, we'll discuss the literature review. So as I've mentioned, there isn't a huge amount of evidence, particularly from randomized control trials around medication use in this population. So what we had to do was we had to start off with a fairly broad literature search to see what type of evidence might be relevant in this population, and then move down into a more focused approach for particular therapeutic classes as we learned more. So we were particularly interested first in looking at existing explicit screening tools, and we identified these from a systematic review by Motter et al. And you can see listed on the left of the slide there, the explicit screening tools that we examined. So we used careful and judicious extrapolation because I've already mentioned that the tools developed for older adults in the general population are not necessarily appropriate for use in those with intellectual disability because we see such different prescribing patterns. But that's not to say that there aren't elements that are still relevant and that might be useful for the population. So we looked at some of these screening tools in order to identify criteria that could be relevant for our population. Then we also looked at relevant reference texts, the Maudsley prescribing guidelines, which cover use of psychiatric medications and come from a UK-based publication, the Frith prescribing guidelines, which are developed specifically to guide prescribing in intellectual disability. We looked at National Institute for Health and Care Excellence, or NICE guidelines from the UK. Looking at Royal College of Psychiatrists guidelines, again from the UK, the British National Formulary is another resource, and then summaries of product characteristics for individual medications. And then from our literature search, we also identified other evidence that we were able to consider when drafting the criteria. So we had 83 records included following our searches and screening. So following our literature review, we then went on to our research team review. So we conducted the literature review, drafted the initial criteria that we felt would be included, and then the broader research team, who I listed on the previous slide, a few slides ago, then had a review of the criteria. And so this involved a refinement process, so the broader research team could look at the criteria that had been developed and give input on those. And then we moved to our focus groups. So a really key objective of the OPTIMA-ID study was to make sure that we represented the views of clinicians who are working with people with intellectual disability. So we held one focus group where we engaged experts in medication use in that group. So we had 2 doctors, we had 3 pharmacists, and we had 2 nurses. And that was to gain perspectives on the tool and to prompt discussion of additional areas which required attention. So we did circulate the draft tool to the focus group members in advance, and they weren't expected to read through or give any detailed information, but it was to get an idea of what would be included in the tool in order to help with discussion. And then one of the key features of the Trinity Centre for Ageing and Intellectual Disability Research is making sure that our participants and people with intellectual disability are represented when we are developing our research. So the motto within the centre is nothing about us without us. And for that reason, we had 2 focus groups where we engaged experts by experience. So we engaged with people with mild to moderate intellectual disability who were able to self-consent to participation to explore their views on medicine use as they get older. And we were very interested in seeing this so that we could then also incorporate that into the criteria as identified. And then we moved on to the Delphi validation process. So once we had refined the criteria following literature review, research team review, and incorporating the views of those involved in the focus groups, we then had our initial criteria that were ready to go for Delphi validation. So we completed this using Qualtrics software. This is an example of one of the prescribing criteria that we developed that we then shared with the Delphi panel. So this one was: do not prescribe polyethylene glycol or macrogol to patients who have dysphagia where liquids are thickened with starch-based thickeners, because there's issues with precipitous loss of thickening if those are combined, whereas xanthine gum-based thickeners can be used with polyethylene glycol and macrogol. So this is incredibly important because we see very high levels of prescribing of macrogol for constipation in this group. And we also see very high levels of the thickeners. So we presented these criteria like this with the wording of the criteria, then the rationale for the criteria, and then the relevant references which were hyperlinked within the Qualtrics survey so that the individuals who were reviewing the criteria could click into them and actually have a look at the references that we used to build that criteria. So we conducted the Delphi validation with experts in medication use. It was an anonymous survey. We circulated it via email invitation, and the respondents were presented with each of the criterion, the rationale and supporting references, and they rated their level of agreement to include this in the tool on a level 1 to 5, where 1 was strongly agree and 5 was strongly disagree. And we also allowed them to include anonymous free text comments, which was very helpful for us then when we were refining the criteria following the first round of Delphi validation. So in order to determine level of agreement, we looked at the median response and the 75th percentile value, and then we had an outcome determined then by the values that we got. So at round 1, we had 101 criteria. There were 63 of these accepted at round 1 by the Delphi panel. 1 was rejected. 23 were removed. So this was if we failed to get consensus on a particular criterion, and there was, say, for instance, insufficient free text comments to improve that criterion within the research team. We reviewed these carefully and we decided to remove them. And 14 criteria were revised for round 2. So that was using the comments from our Delphi panel. At round 2, then we got our Delphi panel to evaluate those 14 revised criteria, 4 of which were accepted and 10 were removed because consensus was not reached, and it was unlikely that consensus would be reached with further revision. So we had 2 rounds of Delphi consensus, and we ended up with a final OPTIMA-ID tool covering 67 criteria. As you can see on the slide, we had a diverse range of experts involved on the panel. And we used an all-rounds recruitment approach whereby any people who were invited to round 1 were also invited to round 2. And so we have here the therapeutic domains that are included in the OPTIMA-ID medicines optimization tool. So we had 11 criteria in the area of general principles of pharmacotherapy. So these are not specific to any one therapeutic group, but tend to be the more holistic management strategies. So for instance, ensuring that non-pharmacological interventions are being implemented for individuals where they have a particular condition that requires that. The other criteria can be divided then according to the anatomical therapeutic chemical classification system. So we had 15 criteria under alimentary tract and metabolism, 9 under the cardiovascular system, 3 under genitourinary system and sex hormones, 2 under systemic hormonal preparations, 2 under musculoskeletal system, 22 under nervous system, and 3 under respiratory system. And the most populous, as you can see there, are the alimentary tract and metabolism and the nervous system agents, which reflects the prevalence of gastrointestinal, neurological and mental health disorders in the population aging with intellectual disability. So we've now moved on to the next step, which is a proof of concept study. So we're very keen that OPTIMA-ID actually be embedded as evidence-based practice. We want it to be used to support clinical decision-making and medicines optimization. And our ultimate goal is to improve quality of care, health equity and status and quality of life, and to mobilize supportive evidence for new policy making for older adults with intellectual disability. So currently, Isabel Ryan is working on applying the IDS-tilde, applying the OPTIMA-ID tool to Wave 5 IDS-tilde data. So obviously there's quite a bit of work in mapping a tool that was designed for use in clinical practice to data collected for research. So of the 67 criteria, 52 have been found to be applicable to the IDS-tilde data and 15 not applicable. And Isabel has been using the software program OR to code functions in order to make reproducible analysis, which can then be modified for other waves. And I suppose a strength of this is that the majority of the criteria that were included in the OPTIMA-ID tool can be applied to the IDS-tilde population. And this is important because it's going to give us a baseline and an estimate of what type of criteria are most prevalent in this group. And this slide is just showing that of the applicable criteria, we had some therapeutic domains which were maybe less represented. So typically the general principles of pharmacotherapy, because that typically relates to, for instance, documentation and counselling of patients where we wouldn't necessarily have the data within the IDS-tilde study to assess that. Whereas we would have good coverage then, particularly for our alimentary tract and metabolism and nervous system categories, which is very important for making sure that we address the most frequent morbidities in this population. So that is the stage that we have gotten to with IDS-tilde, with OPTIMA-ID at this point, but it is still a work in progress. So our ultimate goal is obviously to embed this in practice and to have individuals using it in their clinical practice when they're helping people with intellectual disability. So I'm now going to pass over for the remainder of the presentation to Professor Christine Ryan to talk a little bit about the actual embedding of complex interventions into practice using research.
Thanks, Juliette. So I know this talk so far has been quite heavy methodologically, and maybe afterwards, Juliette, you might share the OPTIMA-ID tool with everybody so they can see the individual components of the criteria and have a look at it and see how it could compare with the tools that you might already be very familiar with, like the Beers criterion, Forte, Stop, Start, etc. But I guess Juliette just asked me to speak to the Medical Research Council framework for complex interventions. So I suppose the methodology that we would follow when we're developing interventions in general, but the one that we're actually following for the development of this particular tool as well, and how we try and influence their implementation in practice. I'm not sure if you've all heard of the MRC framework, but if you haven't, I would suggest that you do look at it. And I suppose in terms of what a complex intervention is, it's something that has 2 or more interacting components. Now, there's lots of advantages, but there's lots of disadvantages to using this as well. The first advantage is that it's very robust. And if you follow the process, if you follow what's here on the slide, the development of the intervention, testing for feasibility, evaluation, which will lead to implementation, and have context covered and considered throughout the process, evidence does show that your intervention is more likely to be implemented and to be a successful implementation. The disadvantage of it is that it takes a lot of time, especially if you're developing an intervention from the very, very beginning, and you don't have an intervention that you're going to adapt for your cohort, or if you don't have the intervention in your mind already, that if you have to develop it from ground up, it does take a long time. So I suppose with this, if you don't have an intervention developed and if you want to do one, the development phase is supposed to take some time. It's evidence-based, so you do a systematic review, you do some interviews with stakeholders, and throughout the process, stakeholders should be involved. And then you look at feasibility testing. Feasibility testing is just, can this be done? It's not asking what's the effect size or anything like that. It's just the practicalities of implementing the intervention. So for Juliette's case, it's the practicality of this OPTIMA-ID tool, the way it's presented. It's presented currently in paper form. Can this be done in practice? Very simple question. How many people need to be involved? How many people do we need to ask before we actually have a number so that we can move on to the next phase of the MRC framework, which would be around evaluation? An evaluation then is like, does it work? How well does it work? Is it cost effective? All the things that you need to answer to produce an RCT that will lead to policy change and implementation of your intervention practice, which is what we're trying to do. But the big things to consider throughout the whole thing is context, and keep asking questions at each of the phases. Is the context right? Has the context changed? Do I need to address anything with how I'm doing this intervention in order to make sure it's implementable? And one example I can give you is one intervention that we did. It was called PolyPrime. It was an intervention aimed at general practitioners to undertake medication reviews for patients prescribed polypharmacy. So to basically improve their prescribing for patients with polypharmacy. It was a behavior change intervention, and we developed it from first principles. We did feasibility testing, we did evaluation. But what happened? The context changed. The intervention was developed for Northern Ireland. GPs very rarely do medication reviews anymore. It's primarily practice-based pharmacists that do it. So the whole thing that we had developed, behavior change intervention targeting general practitioners, should have actually been targeting pharmacists. So it's just a good learning point for us all to keep an eye on the context and the policies and the local policies and how they change as we navigate the MRC framework. And it's lengthy, but if you can start with an intervention that's already developed and adapted for your policy, then do the feasibility, evaluation and implementation. Next slide. So then Juliette. So this is where Juliette is with her team that's working on the OPTIMA-ID tool. It has been developed. And what's really, really good about the OPTIMA-ID tool, if we were to look at all other tools that have been developed, is the concept of making sure that the participants included people who have intellectual disability. So the motto of IDS tilde, nothing about me without me, or nothing about us without us, as Juliette has previously said, was really important in the development of the tool. And then Juliette is going on to test it in a feasibility test and also evaluate it using the IDS tilde, and eventually into implementation in clinical settings that have people with intellectual disability living in them, with the aid of clinical psychologists, clinical psychiatrists, and pharmacists who have specialist interest in intellectual disability. So I think that was it from me, Juliette. I think what we could do is yours, I think, is it?
Yep.
Yep.
So just to finish up with, I suppose, learnings that we've had and how that methodology that we've used could potentially be adapted for other research similar to this. So looking at longitudinal data analysis is very useful, because using population-specific data sets like we have for IDS tilde helps us to identify those prescribing trends and the risks from prescribing as well. So that's something that is a very good resource when looking at moving towards specific intervention development. The Delphi consensus technique is a very useful technique for engaging multidisciplinary experts. And it's also quite useful in that it doesn't involve trying to get very busy experts all together at the same time to discuss. It can be done via, as we've done, anonymous survey, so that individuals can give their input at a time that's convenient to them, and you still get the benefit of their expertise. And really the co-production with individuals with lived experience has been really key for us. So it was a very rewarding part of the development of OPTIMA-ID to sit down with people who will be affected by the use of the tool in practice when we get there, and get their opinions. And it's interesting because I would have gone in with having certain ideas of what would be brought up, and I was surprised by what was discussed, because I couldn't imagine what their experience was. So that's why it was so important to have them involved. And also this OPTIMA-ID tool has provided, I suppose, a framework for development for developing other medicines optimization tools for the unique needs of other vulnerable groups. So the slides will be made available. These are just some of the references that were used just for this data. And then I would just like to acknowledge in particular the participants, families and carers who are involved in the IDS Tilde study, our steering committee and the International Scientific Advisory Board, our advisors and advisory groups, obviously our funders, the Department of Children, Disability and Equality and our Health Research Board. And the OPTIMA-ID tool in particular was funded by Trinity College Dublin Faculty of Health Sciences Dean's Research Initiatives initially, and the ongoing PhD work by Isabel Ryan, it comes from the PANOS Pharmaceutical Innovation PhD Scholarship. So thank you very much for your attention, and I'll stop sharing my slides now.
Thanks, Juliette. And I think these slides will be made available, as I mentioned earlier on, and it might be a good idea to also make the OPTIMA-ID tool available. So now I'm just wondering if there are any questions. And if there are, can you see my slide Q&A? Am I sharing?
No, not yet.
No, of course. Hold on, here we go. There we go. So if anyone has any questions, let me know. You can type it into the chat or raise your hands. I actually can't even see if anyone has any questions. The chat isn't appearing on my screen for me now.
There isn't any questions at the moment anyway in the chat. I just had to look.
Okay. Any questions at all? No. Okay, I just think maybe perhaps it would be helpful if there's one, I think it did come up. Wonderful. But wondering if you could share some of the potential implementation challenges. Okay. Do you want to talk to that, Juliette?
Well, I suppose I can mention briefly. I suppose we haven't tried implementing it just yet. It's still kind of in the early stages, but particularly in the realm of intellectual disability, we would have a lot of different services would be involved, and they would have different practices even around how the medications are dispensed. They might have their own pharmacy within the organisation, or they might be getting medicines supplied by an external pharmacy. And there tend to be quite a lot of different healthcare professionals involved in the management of medicines in people with intellectual disabilities. So they might have, a specialist psychiatrist for mental health, then they'll be seeing a neurologist, particularly for epilepsy management. They'll have a GP who's going to be kind of coordinating that care. They'll often have nurses, clinical nurse managers who are going to be looking after their care as well. And it can be challenging, particularly when it's such a diverse group of healthcare professionals. So it's something that we will need to think about when we are looking at the implementation.
Okay, perhaps one way of getting around that implementation is to have a pharmacist, a resident pharmacist working in each of the settings where they can implement the tool and be the person who looks after the transitioning of care and the communication between the healthcare professionals involved. Anything else from anybody? No? Okay, I'm sure if you have any questions for Juliette, we can provide her email address as well, and I'm sure she'll get back to you. So now we need to look ahead to these are details of the next session will be provided on deprescribing network.ca/journal club. Sorry, something has just popped up on my screen, which is why I couldn't see it. The feedback survey has just been posted, so if you wouldn't mind being able to complete that when you get the chance, that would be really useful. Okay. And also, if you want more feedback or if you want to be involved in the planning of future journal clubs, just get in touch and the details are there. There's an email address and also a Facebook handling for you to make contact. Now I will hand over to Camille, who's going to speak about the International Conference on Deprescribing and do a nice plug for abstract submissions, which I understand is open until October the 15th. So Camille, if you're there.
Yeah, do you hear me, Kristen?
Yeah, I do.
Awesome. Well, thank you, firstly, Juliette and Kristen, for this fantastic presentation. I learned a lot, and I think it's so valuable to hear about the work in people where we see their needs are so high. Thank you. So it's my pleasure to mention that the International Conference on Deprescribing, if you're not aware yet, will be held in Montreal, Canada in April 2026, from April 27 to April 29. So please hold these dates in your calendar. And I'd like to, as Kristen mentioned, indicate that we are now accepting submissions, both for scientific abstracts, as well as for concurrent sessions, including workshops, seminars, and seminars and panels. So if you have ideas, please put them together and submit before October 15th. We'd love to see a variety, a diversity of work presented from all over the world at ICOD. We're welcoming students, we're welcoming clinicians, we're welcoming public members. Really, our goal is to have a very diverse group, both in terms of stakeholders present and countries represented as well. And if you have any questions, feel free to reach out to our team at the Canadian Medication Appropriateness and Deprescribing Network. Thank you, Kristen and Juliette, once again. Oh, you're muted, Kristen.
You'd think after this many years of doing Zooms that I would know to unmute, but I was just saying thank you to you, Camille, and to the ESCP for organising Trinity to give this journal club, in particular thanks to Juliette for leading it. And yeah, if anyone has any further comments or further feedback or further questions or want to discuss anything about pharmacotherapy for patients with or for people who have intellectual disability, we'd be delighted to hear from you. Thank you.
Thank you, everyone.